Hi, this is Roger Green, host of the Surfing the Mesh Tsunami podcast. This week, we're offering 5 conversations from episode 11, in which Michael Charlton joins Jorn, Louise, and me for a far-ranging conversation of recent studies and highlights. Plus, from the vault, a conversation from last year's EASL Congress wrap-up, offering some different thoughts about the role of MASH drugs as adjuvant therapies. Our discussion with Michael Charlton continues as we discuss 2 issues. A, we wrap up the questions around therapeutic futility for Rezdiffra, and B, Michael goes on to describe some issues in translational medicine that interest him. Louise Campbell starts this conversation by asking Michael how he plans to determine therapeutic futility with Rezdiffra in terms of side effects or efficacy. Given that the profile is fairly safe, any side effect issue should be easy enough to determine. In terms of efficacy, Michael indicates he will continue patients on Rezdiffra as long as the disease does not progress. While he would prefer a more robust approach, he describes a scale of challenge in defining futility for a drug where FibroScan and transaminase levels did not provide strong prediction in phase 3 studies. After a slight detour to talk about percentage of patients on GLP therapy, we go on to look at 2 questions in translational medicine that Michael finds interesting. He talks about the liver risk score, a test published in Lancet late last year that appears superior to other wet biomarkers. He and his group are now going through the NHANES database to figure out what they can prove from there. He then discusses work his group is doing on microbiome, where he and others are finding potentially valuable insights. The challenge continues to be how to translate these insights into clinically meaningful interventions. It's been a while since we did an episode with a guest where we simply talked about several issues we found important. So having Michael with us was great, and discussing these topics was fantastic. There's a lot here to think about in a lot of different topics, so just sit back, listen, learn, enjoy, and when you're done, join the dialogue in our LinkedIn discussion group.
Louise Campbell.
It was obviously about the futility, obviously getting people off medications, particularly if they get side effects, as early as possible. Because then the more we identify for futility, the better we can pick the patients coming in to use the medications, because there might be a common denominator in that population as we get further down and longer in the tooth. So he'd self-answered the question I wanted to ask.
Michael Charlton.
But that's a great point about futility. What would be futility? So if let's say you have a patient who comes in with, say, 12, 13 kilopascals of liver stiffness, their FIB4 was whatever it was going in, 2.3, and they have transaminases that were twice upper limit of normal going in. Let's say that at 6 months, those things are exactly the same, maybe a little bit lower, maybe a little bit higher. Would you stop therapy then? You could argue that the patient didn't get worse. That was it wasn't a primary or secondary endpoint, but one of the things that was important was how many people didn't progress. The number of non-progressors was greater on treatment too. So is that futility if there hasn't been some improvement? And VCTE doesn't move that quickly either, so it's hard to know what to make of that. And then you could say the same thing at a year. What will constitute futility at a year? They may not have improved, but perhaps they would have been worse without therapy. So these are things which for sure we're going to struggle with at any price point for resmetirom.
So how do we address the struggle?
I think it's a cardiometabolic disease. I think I'm not stopping metformin when somebody with type 2 diabetes has been on it for a year. I don't anticipate stopping resmetirom necessarily.
So in the absence of progression, that's enough.
That would be enough. In my view, that it certainly will be a discussion I would evaluate, tell the patient, I'm not seeing progression, but I'm also not seeing evidence of meaningful regression. We have the option to continue or to try something else. Something else could be clinical trial.
Roger Green.
Have you had any conversations with payers, or has your group had any conversations with payers about this approach and about how they're defining futility?
At a payers ad board, yes. And it was essentially this discussion, it's not clear in their heads what will constitute a futility or failure to respond. I don't think anyone thinks assessment on treatment is going to be easy to do. If you look at the data for FibroScan on treatment, it really wasn't very predictive. Even transaminases, about a third of people did not have that 17-unit drop on treatment, and yet they were still much more likely to have the histological response. So you can't even really use transaminases to assess efficacy. You should absolutely continue someone on therapy if they do not have an on-treatment transaminase response.
How robust do you feel that is as an interpretation? How well it would hold up over time? What do you think we need to do that gets that better?
We need a different... If people are looking to stop therapy at less than a year, if there's a any concern about drug-induced liver injury of some kind, of course, there are pretty standard criteria for that somebody should come off therapy. Or any other suspicion for some drug-related event, it's a new drug, so it had a really clean set of heals in its phase 3 study, but a phase 3 study is still not that many patients compared to the 80 million people that are out there with MASLD, of which, say, 3 to 5% have F2 to F3.
Michael, will you be using things like patient-reported outcomes, how they feel, and measuring the quality of life improvements as part of that sort of, this is why we keep you on the medication. We don't get progression, we've got better quality of life potentially, so those are all absolutely sound arguments to continue a medication.
We don't do that. Now, I do see over your left shoulder a bottle of, looks like Veuve Clicquot or something like that.
Absolutely.
So those are things that can help with quality of life, at least briefly. But I don't think that the medicine in the clinical trial, it didn't do anything important, I think, for increasing or decreasing. It's not a feel-good medicine per se, and we don't record PROs really. So maybe we should.
Jörn Schottenberg.
Yeah, I think that exceeds the clinical routine. I mean, we're moving outside the clinical trial, and I would actually do the same as Michael said. I think that we have a lot of data for the phase 3, so giving the drug of over 1.5 years, there's robust safety data, no really concerns. If there is a good indication, patient is not cirrhotic, it's good to initiate and keep the patient on it for at least some time. I struggle a little bit with the NITs, as you highlighted too, Michael. Not sure what I would do. I mean, the patient comes back asking you about, my tests do not get better. What should I do? So I'm thinking there might be compound situations where if nothing improves, you can consider to, as you said, maybe switch. But if there's no side effects, keep them on the drug and try to maintain long-term benefit. And the important thing is, that the clinical trial is ongoing and outcomes data is going to be collected. So we'll learn more down the road.
I think the fact that 30% of people who didn't have a transaminase response still had a histological response is what I'm going to tell patients, and then give them the choice of persisting or not. If they're having otherwise a pretty event-free course of therapy, I suspect many would want to continue.
Slightly or meaningfully different question. How many of the patients that you're seeing that you consider good candidates for resmetirom are currently using GLP-1s?
30 or 40%, at least that.
I was wondering whether the number was under or over half, and what you're saying probably under, but not by much. Michael, let's switch to part B, which is to talk about what your research has been about recently. You mentioned a lot of translational issues. Those are kinds of things we haven't talked about here enough recently. So if you could share with us what you've been working on and what you're learning, that would be fantastic.
So I think probably the most interesting thing that's in process right now, we don't have the results yet, is looking at, there was this new test developed by the Barcelona group, Pere Ginés, among others, and they were looking at something called the liver risk score, published in, I think it was Lancet, that looked substantially superior to what we've been using to date in terms of wet biomarkers. So compared to, say, FIB4, I think APRI was in there as well. So we're now looking at this in NHANES, the National Health and Nutrition Education Survey, and we'll see if it's predictive in a group who had transient elastography and met criteria for MASH. It will be interesting to see if this is a dynamic endpoint. It has components that can be dynamic, including transaminases, for example. So I think it looked in the Lancet paper to be a really noticeable new advent. And the other thing I think, which was interesting, we had some microbiome work that we've just published that if you have germ-free animals and you give them the same fast food diet, high cholesterol, high fructose, high carbohydrate, high fat diet, they're totally resistant to the histological phenotype. So as you know, the spectrum of response to any therapy is really substantial. Now, whether some of this is predicted by patient microbiome is an interesting question. It's becoming easier to assess patients' microbiome in the clinical setting. So that's something else which I'm hoping emerges as something which has more meaning or direct relevance in the clinical setting.
I saw that paper, and one of the things that, at least I saw an abstract of it, one of the questions that struck me is whether the converse is true. And I saw a paper from Vincent Wong suggesting that, which is that, in fact, the impact of diet becomes a heck of a lot stronger when you're dealing with people who've got bad genotyping or who might have microbiome problems to start with. How do we address that practically, or can we address that practically yet in treatment?
It's been hard. So it's been hard to get engraftment of microbiome therapies. So there's a company called Synlogic that just went bankrupt. I think it totally folded. They were giving therapeutic bacteria. They had spliced into these things like enzymes to deal with phenylketonuria. So essentially replacing the enzyme that's lacking in patients with PKU. It didn't work. And they had enzymes that would metabolize proteins in a way that was less ammoniogenic as well. Also failed in phase 2. So I think the difficulty has been translating an observation in the microbiome space into something that's clinically helpful. So I think that's the next big hurdle is getting across. Remember that the stomach is highly acidic and the small bowel is almost sterile, not quite, but it's close. So we have to somehow navigate what we're putting into the microbiome. If we use an oral route, have to navigate the acidity of the stomach and the other perils of the small bowel, or we use a south to north approach, and then you end up, how do you get beyond the rectum, for example? There are some really notable challenges in microbiome therapeutics.
Well, to me, the microbiome, it's so difficult, Michael, because the complexity of the function and the number of microbes we're looking at, and obviously the layer you're looking at, which technology are you using, and we're not well standardized yet. And I think I see the hurdles why this is not a straightforward study opportunity. I always thought it could be in the biomarker field, could support us and help us a little bit, but most of it is associations as far as I can tell. And so, more research is welcome here, and I think it's great to hear that you're working on this.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded the conversation, or send an email to questions@surfingmesh.com. We're working on next week's topic, but it will be at least as good as this week's, maybe even better. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.